the audience is joined?
Yes.
Okay. Well, good day, everyone. Thank you for joining us for this webinar as part of our Comparative Effectiveness Research Committee series of webinars that we've been doing recently. The topic today is on pelvic focused ultrasound treatment, and the focus of the talk is really on prostate cancer and uterine fibroids. We have two fantastic speakers that are talking about the two separate topics. The first one is Dr. Gina Hesley from Mayo Clinic. Her topic is MR-guided focused ultrasound treatment of fibroids. Dr. Susan LeBlanc is going to give a little introduction of Dr. Hesley, and then she's going to share her talk with us. Susan.
Great, thanks, and welcome everybody. As you said, my name is Suzanne LeBlanc, and I'm the Director of Clinical Relationships at the Focused Ultrasound Foundation. Over the past few months, as I worked with the various team members at CER, I've been impressed with their wide breadth of services and roles that they play. And as a radiologist myself, and because focused ultrasound is an image-guided procedure, I feel very strongly that CER and the FUSF Foundation need to work together and ensure that CER members become aware and involved in the over now 161 focused ultrasound clinical indications at various stages of research and regulatory approval. In fact, to date, there have been over 151,000 treatments for uterine fibroids and 88,000 treatments for prostate treatments. So I'm sure you're going to enjoy the speakers today. It's my pleasure to introduce our first speaker, Dr. Gina Hesley, who I've known for many, many years. She's an associate professor of radiology at the Mayo Clinic in Rochester, Minnesota. She specializes in ultrasound and women's imaging and has been involved with focused ultrasound since 2000. She's been an invited speaker at numerous meetings to share her vast expertise on focused ultrasound and has a unique perspective, having been involved with the technology since its infancy. So I'm sure you're going to learn a lot from her and enjoy her presentation. So Gina, the floor is yours.
Thank you very much. So it's a pleasure, and I appreciate the invitation to share some of the information that we've gathered over the years with focused ultrasound, both at our institution as well as the many institutions across the world. So today, I did want to disclose the fact that I have been a trial investigator with the company Incitec over the years. But what we're going to try to cover in the next about 20-25 minutes is many objectives. So we're going to try to talk about the basics of focused ultrasound, how it works, some of the benefits, how we perform patient selection for this, and as well as some of the risk encountered with focused ultrasound. And then we'll talk about the outcomes.
Gina, sorry to interrupt.
Yep.
We don't see your slides.
My
you want to share your screen?
I'll try again. Yes. Thanks for letting me know that.
No worries.
Are you seeing them yet?
I don't see them. No.
Okay. So I've hit share screen.
We can see you, but I don't. Is anybody else able to see it? Because I don't.
Okay.
There we go. Something is
better?
Yeah. Yeah.
Okay. Nope. Thanks for letting me know that.
And then, yes, perfect.
There we go.
Awesome. Yep.
Okay.
Thank you.
A couple of things around down there. Okay, so as you're aware, fibroids are extremely common. They're the most common benign tumor in women of reproductive age, more common in African American women as well. Only about 25% of the women who have fibroids seek treatment, but again, being an extremely common treatment, is well needed. Now, there are multiple options for treatment, including medical therapy, uterine fibroid embolization. There's a host of surgical options for treatment, including laparoscopic, hysteroscopic, myomectomies, as well as hysterectomy. But focused ultrasound is kind of relatively new, although it was FDA approved in the US in 2004. So it works similar to how a magnifying glass focuses light energy. In this case, we're focusing sound waves to generate high energy densities, which results in tissue heating. If you heat tissue up enough, you can cause protein denaturation and subsequently cell death. There are different ways to perform the guidance for focused ultrasound therapy. Ultrasound guidance is used widely, especially in Europe and Asia, with MR guidance being the only way it's FDA approved in the US. Currently, there's only a single device approved in the US for the application of fibroid treatment, and that is the Incitec device, the Exablate 2100 currently. So this is a schematic little animation showing how the treatments perform. So the ultrasound transducer is embedded in the table in a 1.5 Tesla scanner. It's surrounded by then degassed water. And then that ultrasound transducer can move within the unit and be able to angle and tilt to be able to access different areas of the fibroid. And that transducer can also translate within the table towards the patient or towards the fibroid, which can decrease the energy density on the skin. So the MR value add really has multiple factors. You certainly get these exquisite anatomical images that we can use for treatment planning to define not only the fibroid itself, but a multitude of anatomical structures that maybe we want to avoid, like the bowel, knowing the location of nerves so that we can minimize the impact on them. The location of if patients have scars, we can see those on the skin to again avoid. And if a bowel is interceding between the area of the ultrasound beam and the area we desire as the target. The other thing MR provides is thermometry. So we can get real-time thermal feedback while we're performing the procedure to determine, do we have enough heat being generated to enact an adequate treatment, but also keep it within safe levels so we can keep our patient comfortable. We also get that feedback so we know where the energy is being deposited, and so we can safely say it's within the fibroid itself and not hitting any other non-intended targeted structure. We also get feedback to be able to know, did the patient move or did our fibroid move? I have seen cases where the patient had an anteverted uterus and during the course of treatment, it became retroverted. So the nice thing is there's safety things built into where if we notice that with that, once we get the updated images, we can immediately stop treatment and again, get the patient in a safe location so that we can continue with treatment. The other thing you can do is assess outcomes following treatment through the administration of gadolinium to see these non-perfused areas following treatment. So some of the benefits of focused ultrasound include the fact that it's non-invasive, it's an outpatient procedure, there's no radiation involved, and the patients return to their normal activities very quickly. We've had patients return the following day to whether it's to their work or to an active family life. There is a very low rate of complications. They do occur, and we'll kind of discuss those a little later on. But most post-procedure discomfort is handled with over-the-counter acetaminophen, so no need for narcotic-type pain medications, which for many patients these days is quite an advantage as well. So patient selection with focused ultrasound is extremely important because it's certainly not geared for every patient. Not every patient is going to have fibroids that respond well to treatment. So we look at the size of fibroids. We want fibroids that are going to be smaller than extending above the umbilicus, because if it extends through or up to the level or above the level of the umbilicus, we can't treat through that because air will be trapped in that umbilicus. Ideally, you want fibroids that are less than 10 centimeters in size. If you have larger fibroids, there are other methods we can use to try to decrease those initially, such as GRNH agonists, to be able to shrink the fibroid and then proceed with treatment. We look at the number of fibroids. Again, it's a targeted treatment. So if patients have multiple similar sized fibroids, they're not as well suited for focused ultrasound treatment as patients who have fewer fibroids would be. We also look at the signal intensity of fibroids. It's been found over time that fibroids that are low signal intensity on T2 weighted images and homogeneous respond the best. The more heterogeneous fibroids are, the more energy we know that we're going to have to put into those fibroids, and the tighter we're going to have to pack that energy to achieve a good thermal ablation. Bright fibroids, we know, have a lower efficacy rate of treatment with focused ultrasound and are not as well suited. We also look at the enhancement after gadolinium. Since we're trying to achieve non-enhancement, if a fibroid already is non-enhancing, those patients don't require treatment. And then finally, we look at the correlation with the patient's symptoms. So patients who have bulk symptoms, we typically are going to expect to have large or multiple fibroids that would result in those sort of symptoms compared to patients with bleeding symptoms, which may abut the endometrium or cause distortion or elongation of that endometrium. We also want to take into factors things that might alter our treatment, either planning or again, make the patient not suitable. So patients who have peripherally densely calcified fibroids, the calcium deposits actually would intensely absorb the energy. And so that might result in unintended heating of adjacent structures. So depending on where the calcifications are, they can be problematic. We want to look for scars. We know that patients who have surgical scars are at increased risk for skin burns. So knowing where the scar is and seeing if we can be able to treat around that scar, or in certain cases, if we have to go through the scar, being able to have good informed consent with a patient of their increased risk of potential skin burn, and also knowing that we need to take certain mitigation strategies to avoid causing skin burns. We also look to see on the screening images to see how much, if any, bowel is between the area that we're going to treat and the ultrasound transducer itself. And then again, it helps us in the planning, knowing that we may need to do certain things such as put ultrasound gel in the rectum or fill the bladder to be able to achieve a safe treatment. So our ideal patient is a patient who has one or only a few fibroids, a fibroid size that's somewhere about 5 to 7 centimeters. That's usually large enough that it'll move the bowel out of the way and make for an easy, safe treatment path. We like them that they're, again, homogeneously dark on those T2 weighted images. Those tend to absorb the energy and treat the easiest. Again, no intervening bowel or scars in the way that would have to make for a difficult obstacle to get around. And those that typically enhance equal or slightly less than the adjacent myometrium. And then finally, we want to make sure that the fibroids do likely correspond to the patient's symptoms, so that this is all designed about symptom relief. So we want to make sure that we achieve a good symptom relief for the patient following treatment. But the reality, of course, of patients is that many of them have multiple fibroids, maybe large fibroids, heterogeneous bowel and scars. So again, we have to have lots of little mitigation strategies that we can use, or also looked and try to counsel the patient towards other options that may just be better options for them than focused ultrasound is. During the course of treatment, one of the common questions we get is, what type of medications do patients receive to help keep them comfortable? We typically use medications that are common in endoscopy suites with midazolam and fentanyl, but at much smaller doses, so the patients are completely awake during treatment. We also like to use an anti-nausea medicine in our practice. Again, a lot of these patients haven't had anything to eat or drink for a while, and putting those narcotic medicines on top of an empty stomach oftentimes lead to nausea, especially when they're lying on the stomach. That's less than ideal. So Zofran is a great drug that works very effectively for this. The other thing I find during treatment, if patients notice that they have a lot of discomfort in one particular area, I try to move to a different area of the fibroid itself, treat there, try to get their confidence in treatment again, maybe treat them at a little lower energy, and then just kind of work back into a good thermal ablative treatment. And that often helps the patient be more tolerant of the procedure itself. What do we do for long-term follow-up in patients? Again, this is really geared currently towards symptomatic patients. So we do mainly clinical follow-up in our patients. We follow our patients from 1 week out. We're looking for complications of treatment such as DVT or urinary tract infections. But then our real clinical follow-up for symptoms is at 3 months, 6 months, and then yearly for 5 years. We only do imaging follow-up typically if the patients have recurrence of their symptoms. Of course, imaging is so expensive to obtain for the patients, and it's not always covered. So we want to make sure that we're only using it in times where that might impact their management. So what are some of the potential complications and some of the things that we can do to mitigate those? Urinary tract infections occur because we're placing a catheter in the patients prior to treatment, so that we can make sure that we know that the bladder is either drained, or if we need to fill it to be able to push bowel out of the way. Skin burns occur predominantly when there wasn't the realization that you need to have patients shave their skin from the umbilicus to the pubic bone. The little hairs there could trap small amounts of air and result in skin burns. So knowing that, and then knowing that surgical scars can absorb heat differently, has really decreased the risk of skin burn in many practices. You can have edema in the subcutaneous fat. We typically find that in patients who have a larger subcutaneous fat layer and where you're going to have to put larger amounts of energy. So if you're going to treat a more heterogeneous fibroid, a fibroid that's brighter, those are going to require more energy And so therefore they're at higher risk to have that. What does that really mean to the patient long-term? There's a little discomfort if they push on their skin, but we haven't seen any patients develop open skin wounds, any type of abdominal wall hernias if it occurs in the abdominal wall at all. Nerve injuries, those have been seen in patients where they repeatedly stimulate, even in the far field, the lumbosacral plexus nerve. If you do that multiple times, patients can end up with a temporary or potentially a permanent nerve injury. Mitigation of that is largely by good communication with your patients. Again, they're awake during the procedure. If they feel pain go down one leg or the other repeatedly, you can do many things such as angling the ultrasound transducer to try to avoid stimulating that, go to a different area. And then the other thing is the exoblade device has some markers where it can help you anticipate where you might be potentially depositing more energy on those nerves so that you can avoid that. Bowel injuries, again, being able to see the bowel, the uterus during the course of treatment with this real-time thermal feedback and real-time imaging as you're delivering the sonications is very helpful, because you can see in this case where there was bowel in front prior to treatment, and then through the administration of ultrasound gel in the rectum, able to push the uterus forward and push this bowel out of the way and be able to have a safe treatment. Here we can see that we actually fill the bladder to be able to push bowel out of the way to enact treatment. And then sometimes it takes both strategies to be able to achieve this. And then honestly, sometimes after you achieve both, if you now remove the fluid from the bladder, now the uterus will fall back in front, but the bowel won't follow, and you'll still be able to achieve a good, safe treatment. So many things can be done to decrease the risk of bowel injury. And part of it is just cognitive watching every time you're delivering the energy, making sure that there's nothing between the ultrasound transducer and the fibroid that you're treating. Other less common things that can occur too, deep venous thrombosis. Patients are on the table for about 4 hours on average for treatment. And even though they sleep longer at night, they have less involuntary movements. You can put compression stockings on patients, do different things to decrease the risk slightly in those cases too. Whether you use knee-high stockings or thigh-high stockings, you might slightly decrease that risk. That's a little controversial whether you enact that type of pre-treatment preventative measure, but that's one option that you can have. Other things that are less common too, if you're treating very large tumors, you could consider tumor lysis syndrome is potential. It's very uncommon. Fibroid expulsion, again, based on the location of the fibroid. And then the other thing to consider are the inadvertent treatment of a leiomyosarcoma. MR certainly gives us the best advantage of being able to see the fibroids and try to see if there are any unusual features that might clue us into leiomyosarcomas. But bottom line is, none of these fibroids have undergone biopsy to where you would know actually the cellular makeup of these. When it comes to outcome, there's certainly been a continuous evolution as interventional as well as surgical techniques have evolved. And then there are also many types of outcomes that people look at, whether that's the volume ablation, patient symptom improvement, reintervention rates, comparison also of, we want to compare other interventions and surgical options to one another. So if you look at the 1-year follow-up, multiple people have published their work of their 1-year follow-up of their patients, and you can see the rates range between about 3 and 8%, again, depending on what you include as a reintervention, whether that's surgical or if you include medical therapy in that. But these rates are on the order of those that have been published with urinary embolization and myomectomy in the order of about 7 to 10%. If you look at longer-term follow-up, we published the rates out of our practice a few years ago, and they were rated between 13 and 23% at 2 to 4 years. And again, others have published their work on this. This was out of Funaki's work, and he actually looked at a comparison of dark fibroids versus fibroids that were bright. And you can see that there was a difference between those that were of low signal intensity versus those that are bright. And the bright fibroids tended not to respond as well and have a higher likelihood of reintervention. But those reintervention rates, again, are very similar for that of urinary embolization as well as myomectomy. There's been, of course, changes in our technology with focused ultrasound. The Exoblate 2100 came out and was FDA approved in the US in about 2015, approved with the CE mark in Europe prior to that. And some of those early studies have shown much higher non-perfused volume ratios. And we know that those ratios lead to improvement in patient symptom relief, as well as a reduced number of patients needing additional intervention. When it comes to fertility, in summary of kind of the things that have been published, we've seen no increased rate in the spontaneous abortions or pregnancy complications in patients following focused ultrasound, whether that's MR guided or ultrasound guided. And there's been no impairment in ovarian function found in the few studies that have been done on that as well. So one of the early studies that was published about the pregnancy rate was the multi-institutional study that came out of the MR intervention practice, where there were 54 pregnancies in 51 women. And I think the surprising thing here, I found that even though it was quite early on, this is back in 2010, again, FDA approval was 2004, the vaginal delivery rate was actually 64%, which is pretty high considering it was a very new technology. Similarly, we've seen with ultrasound-guided technologies when they published on pregnancies. This is a more recent study where they had 71 pregnancies in 55 patients. You can see 82% of the patients actually had a natural pregnancy, and 57% of those patients had a vaginal birth. This largest study I've seen was actually recently published in the International Journal of Hyperthermia, and they actually looked at 346 patients and looked at patients who wished to conceive, and 152 of the patients had ultrasound-guided focused ultrasound, and 194 had laparoscopic myomectomy. And they found no significant difference in the pregnancy rate between focused ultrasound and the myomectomy groups. When it comes to cost effectiveness, again, there have been a few studies done. Now, these are very dependent on the modeling assumption, but the differences in effectiveness between either myomectomy, focused ultrasound, and urinary embolization are found to be minimal. And when they look at hysterectomy too, focused ultrasound has been shown to be cost-effective as a first-line therapy. So many studies, again, showing that there's good cost effectiveness when it comes to focused ultrasound. When it comes to reimbursement, while it's been approved for a long time, we still have challenges with insurance. And honestly, it comes down to a case-by-case basis and usually going through the appeals process with the patients. Our practice has been very successful in getting insurance coverage. We're over 80% typically in being able to work with their insurance companies and get approval. But it does require many months, usually working with the patients to be able to achieve actual successful coverage for them. Finally, I'd just like to say that, I think when we look at the future of focused ultrasound, I think one of the things that we found that is so important is not only collaboration with our referring providers, but also learning from other providers. We've been fortunate to work with providers from across the country as well as across the world to learn new innovative techniques. And we really value those relationships and appreciate those as we work towards providing the best patient care possible. And I'm happy to answer any questions.
Well, thank you, Gina. That was an amazing presentation, and you took a lot of information and really condensed it into an easily understood fashion. So
I had a question.
Go ahead.
Gina, that was awesome. Thank you so much. I had no idea about any of this, so I learned a lot. So one question I had for you was, how long does a typical procedure take in the room?
Yeah, so the actual treatment itself is about 3 hours. The patient's on the table for about 4 hours, and that's really positioning time. And then once we're done treatment, getting some post-procedure imaging, and then just getting her off the table back to dressed in nice warm clothes.
And these areas that you treat, is there any automation in the software that you can just plan and basically ablate those areas, or do you have to do it manually as you go through it?
You can group the sonications and plan out multiple at a time, but each one of them you do want to be watching and be able to actually stop treatment. Again, if you see something that becomes unsafe during the course of treatment, you have the ability to stop any of those. So even though you may be automating and setting up multiple at a time, you still do lack that. You still do have the safety aspect of being able to stop any of those if you see something change.
Got it. And last question I had was, so a typical device that would do this, you said only in the US, there's only one device that is FDA approved?
Correct. Right now, the only one that's approved with a application for for fibroid treatment is the Incitec device. So Sonaleave is approved, but it's for osteoid osteomas, but it has been used elsewhere and has, I believe, the CE mark for approval for treatment for fibroids, but just not in the US.
Got it. So do you have a rough estimate of what the cost is to set that up?
To get a device and
yeah.
That's a great question. I really don't know because for our institution and such, it's done with a big group buying, and I'm not in charge of purchasing of the device. So I don't really have an idea of the exact cost. You would have to have room in your MR suite to be able to have outside of the control area, a separate place in your equipment room for the additional equipment, and then a place to store the special table that's associated with a focused ultrasound.
Okay. And you said you do all of these with moderate sedation, correct?
Correct, right. The patients are awake, but they're under some moderate sedation. We have had a few patients who've done it without any sedation, but we try to make sure that they're at least willing to take some if needed.
Got it. Well, thank you so much. This was great.
Gina, can I ask you a question? So, for the interventional radiologists on this call who are used to working with catheters and, doing things with their hands and seeing things move, can you explain a little bit about the learning curve and how to translate those skills into an image-guided, non-invasive procedure, and how long you think it takes to learn how to do this well and the skills that you need to do it?
Yeah, so I think the biggest skill is being able to look at MR images well, which, the interventionalists are usually exceedingly good at because they do this all the time, and they were also trained in their diagnostic radiology programs to do such. But I think, having that for the safety aspect is very, very important. Otherwise, I think, the skills to be able to do it, they're well comfortable with discussing things with patients, which I think is really critical as we look to add individuals to our practice. Having somebody who can speak to patients, be able to explain appropriately their risk and benefit in a way that the patient can kind of understand. Being able to do the treatment itself, probably 10 to 15 treatments kind of get you off the ground and running. And certainly being able to, just be able to phone a friend and ask some questions as you go along. But I think would probably be the learning curve of probably an average interventionalist, potentially a little faster for some.
Okay. Let's see, I think we have one question. Can you comment on the ultrasound guided versus the MRI guided systems? I know you only use the MRI guided systems, but I know you know a lot about the ultrasound guided systems and the advantages and disadvantages. For people out there, there are a lot of regulatory approvals for the ultrasound guided systems outside of the United States, not in the US yet, but Gina, why don't you kind of highlight the differences and advantages and disadvantages?
Sure. No, I think, it's interesting that we've never been able to get an guided ultrasound system approved in the US yet. So we haven't been able to have the experience with it. So a lot of mine is just from the reading of it. And like I said, my experience with the MR side. I think, we're very spoiled in being able to see these beautiful images and feeling very comfortable with being able to know when there's subtle changes in the location of bowel or other things. But certainly with my experience with ultrasound, I would say that, they've overcome that in many cases as well. And they can guide it as well as being able to monitor it in a different way. I think the ability to use ultrasound contrast too helps them in that they can kind of check on things as they're going through treatment, being able to assess through microbubble administration whether they've got enough non-perfused volume or if they can choose to do some more ablation with it as well. So I think, with the experience and everything, I think you're able to achieve very similar outcomes with both technologies.
Yep. Okay, thanks, Gina.
Mm-hmm.
I think we'll move on to the next speaker. So it's my privilege to introduce Dr. Peji Ganuni. He's an associate professor in the Department of Radiology at Stanford University with courtesy appointments in gynecology, neurosurgery, and urology. He's interim division chief of body MRI and directs the Stanford Minimally Invasive MR Interventional Center and co-directs the Stanford Focused Ultrasound Center of Excellence. Over the past 10 years, he has treated hundreds of patients with MR-guided focused ultrasound, including uterine fibroids, bone metastases, and essential tremor. Currently, he is part of clinical trials investigating the use of the technology for Parkinson's disease, epilepsy, and pancreatic cancer. He was also part of the clinical trial that recently led to FDA approval of the technology for treating the prostate. He and the MEMRIC team routinely use MR-guided transurethral and transrectal ultrasound ablation, as well as MR-guided cryoablation to treat patients with prostate cancer. So I'm sure you'll enjoy the presentation, and Peggy, take it from here. Peggy, you're on mute.
Thanks a lot, Dr. LeBlanc. And I'd like to start by thanking Dr. Kirkavi and Ahmed for inviting me to speak on this topic. As Susie said, my name is Paige Ganuni at Stanford. You can see images here of the different applications of ultrasound ablation that are in routine use by our MEMRIC team, treating essential tremor, Parkinson's disease, bone and soft tissue tumors, the uterus, and the topic for today, the prostate cancer. These are my disclosures, including receiving research funding from Insight-Tech to conduct clinical trials. I'm also on the medical advisory board of Sonalisense and Insight-Tech, and I've been a consultant for Sonication. To start with, we know this, prostate cancer is common, with about 12.5% of men expected to develop the disease in their lifetimes. Of these patients, about 73% present with localized disease. What's interesting, of course, is that standard treatments for this disease are of unclear benefit. I've tried to summarize here a number of large, long-term follow-up randomized studies looking at standard treatments, including prostatectomy and radiation for prostate cancer. The SPCG4 group has at this point published the results of 695 men with clinically detected tumors. So these were in the pre-PSA screening era. These men were randomized to watchful waiting or to radical prostatectomy. There was a report at 6 years, in which a median of 6 years, in which radical prostatectomy significantly reduced disease-specific mortality, but there was no significant difference between surgery and watchful waiting in terms of overall survival. A subsequent 29-year follow-up has been published, which showed benefit to surgery in men diagnosed clinically, but much of that benefit occurred after 10 years of follow-up. And again, this was primarily men that were diagnosed in the pre-PSA era, so tended to be men that had more advanced disease. Subsequent studies, including Pivot, published a 20-year follow-up of men with localized disease. This was the prostate cancer intervention versus observation trial, published in New England Journal, again showing that among men with localized prostate cancer, so now this is a group that was kind of in the early PSA screening era, men with localized prostate cancer, surgery was still not associated with significantly lower all-cause or prostate cancer mortality over observation. And then a third study now, Protect, in which men that were now diagnosed in the PSA era, so men diagnosed initially with elevated PSA, leading to diagnosis of localized prostate cancer. 1,643 men participated in this study, and they were randomized to either active surveillance, so not just observation, but active surveillance with PSA, with MRI, with biopsy as needed. A third of the men ended up in this active surveillance group, a third went to surgery, a third to radiotherapy. Again, at 10 years of follow-up, no difference in outcomes in these different arms here. And actually a very low rate of death from prostate cancer at 10 years, independent of the treatment that was used. Add to this that standard of care radiation and radical prostatectomy for localized prostate cancer continues to fall short of the goal of excellent oncologic control, unchanged urinary function, including preservation of continence, and the ability to maintain baseline erectile function. In terms of oncologic control, standard treatment often requires reintervention for recurrence, with rates of reintervention often reaching more than 20%. Now, in addition, men suffer high morbidity from these current standard treatments. So in Pivot, for example, we see that urinary incontinence and erectile dysfunction were greater after surgery over observation through the 10-year follow-up. Here, Hoffman and colleagues compared 1-year recovery of urinary and sexual function among approximately 3,600 men treated for prostate cancer. Less than 40% were potent 12 months after nerve-sparing radical prostatectomy. Only 50% were potent after external beam radiation therapy. Nam and colleagues here published on a greater than 30% 5-year cumulative rate of follow-up urologic procedures after prostatectomy and radiation. And, you know, in the context, these adverse event rates in the context of a lack of definite benefit reported for radical prostatectomy or radiation have led to the adoption of strategies that are built more around active surveillance for early stage disease. However, what we saw in PROTECT was that surveillance often leads to treatment. So if we look at these groups that got radiotherapy or surgery, and you look at the active monitoring group over this 10 years, we see that by about 5 years, 40% of men randomized to active monitoring have gone on to actually receive radical therapy of some sort. So even the surveillance group often proceeds to treatment and ends up suffering some of the morbidity associated with these whole gland approaches. So I'm going to switch gears a little bit, and having introduced some of the background about issues about standard treatment, I want to touch on the concepts behind focal therapy and then go into what where we are now with our knowledge and our application of ultrasound-based methods of focal therapy. So one of the key concepts is of the index lesion. And the theory here is that there's one dominant focus within the prostate that usually causes local and systemic progression and eventually disease-related death. And the idea behind focal therapy is that the management of localized prostate cancer basically follows the idea of organ preservation approaches taken in the treatment of a lot of other solid tumors, going from mastectomy to lumpectomy, going from nephrectomy to partial nephrectomy, and to now focal ablation methods there. Focal therapy treats this index lesion within the prostate along with a margin of normal tissue, and it leaves surrounding tissue untreated and under surveillance, including if there are insignificant foci elsewhere in the gland. And the proposal, the idea behind this is that by preserving the normal prostate and the surrounding structures, the urethra, the sphincter, the neurovascular bundle, we can reduce side effects. Key to all of this, of course, are that multiparametric MR and biopsy are enablers of the implementation of focal therapy because they're needed for visualization and confirmation of clinically significant prostate cancer, for treatment planning and delivery, and also for monitoring of treatment outcomes. So these are meant to be examples of patients that would be potentially candidates for focal therapy. Here's someone that had a lesion outlined in blue on an MR, and then these biopsies confirmed that the grade of the disease. Here's someone that not only had this disease that was visible on MR, but other clinically significant disease seen on biopsy that could potentially be a candidate for not necessarily focal, but perhaps a hemiablation approach to therapy as well. We'll hear more about this in the rest of the talk. Now, this index lesion idea, again, the premise derives from the idea that, and from data, that metastases in prostate cancer have a common origin, that they originate from the same clone. Liu et al. Here analyzed 94 samples of malignant tissue from metastatic sites in 30 men who had died of disseminated prostate cancer. And using a method of analyzing single nucleotide polymorphisms, they concluded that anatomically distinct metastases within the same patient came from the same precursor, single precursor. And this is the premise then, is that if we can then kill this index lesion, we can prevent the spread of the disease. And if we can kill that index lesion in a focal manner, we can avoid the side effects of whole gland therapy. Now, the counter argument to this, of course, is that prostate cancer, as we know histologically, is commonly multifocal. And so the argument would be that whole gland therapy is needed to treat all the cancer. But what we've seen, and there's a very nice paper from Karavitakis that you can refer to. Karavitakis took 100 consecutive prostatectomy specimens. And it is true that tumors were often multifocal, about 70 to 80% of the time, and often bilateral, between 80 to 90% of the time. However, what they found is that even in multifocal disease, the overall Gleason score for that patient, the total tumor volume, and the tumor stage were almost invariably determined by the index lesion, by the leading lesion, by the thing that typically is visible on MRI. And that non-index foci tended to be quite small and tended to be well differentiated and hence clinically insignificant in terms of risk of spread. So this has been a key component of rebutting this counter argument. The next step, of course, is multiparametric MRI. We know as PIRADS has gone from version 1 to version 2, actually starting off with Likert scores, so then version 1 and then version 2. Clearly, there's continued improvement that's needed. multiparametric MRI is not a perfect detection tool. But if we look at results, for example, from Wu and colleagues, we see that a systematic review of the diagnostic performance of PI-RADS version 2 for detection of prostate cancer, they looked at 21 studies, 3,800, more than 3,800 patients, and they saw that the overall pooled sensitivity for prostate cancer diagnosis was 89%, specificity was 73%, and if we look at clinically significant disease, again, 89 and 64%. So very, very good sensitivities here. If we look at the precision trial, which was the prostate evaluation for clinically important diseases, and basically deciding on whether sampling should be done using image guidance or not, we can see the detection rates for clinically significant prostate cancer, so using PI-RADS to score as 3 or 4 or 5, led to, in men that had no prior biopsy, led to positive clinically significant biopsy results in 12, 16, 83% respectively. Now, at least some validation studies have also looked at the sensitivity for detecting index lesions, which tends to be quite high. These index lesions are almost by definition the largest and most evident lesions on MR. And so typically we'll see numbers around 90% for detecting these index lesions. We also see that the index of agreement in some of these studies is quite high for the detection of the index lesions in particular and for scoring. Now, as a counter to this, of course, are work that shows that actually inter-observer variation is high. So in reference to that, a study by Son and colleagues here at Stanford, they looked at 408 males and 503 MR detected prostate lesions. And they found that actually across radiologists calling PI-RADS 3 or 4 or 5 lesions, even for 4 and 5, the range for significant cancer detection rates were between 23 to 65%, and for PI-RADS 5, 40 to 80%. So quite a range and substantial variation was shown in that study. Another counter to the dependence on MRI is Lenobin's work, where they reported that when comparing MR to histopathology in 33 patients, they were reporting on the idea that the detection of extent of disease is poor. So if you're going to use MR to identify your tumor and then to kill that tumor with focal ablation, the MRI better show you the full extent of the disease, or you're going to, by definition, undertreat. What Lenobin did when comparing MR to histopathology is they recognized that actually for Gleason greater than or equal to 7 disease, the lesion diameter seen on MR underestimated the extent of disease by typically by around 2.5 millimeters or so. So what they found is that if you actually put a 9 millimeter diameter around your visible lesion, then at least in their cohort, you would kill about 100% of the tumor that was seen histopathologically. Similarly, Priester et al. Used patient-specific molds to align prostatectomy specimens to MRI in 114 men. They reported that about 80% of the cancer volume from matched tumors was outside the region of interest boundaries. So when they looked at the lesion that was drawn on MR by the radiologist, they could see that cancer extended well beyond that lesion. And you can see that in plane and through plane, the additional diameter that was needed, or the additional radius that was needed to capture the rest of the tumor. Now, histologically, this underestimation may be due to the fact that sparse areas of prostate cancer can be present at the periphery of the index lesions, and it can be admixed with normal tissue, intermixed with these malignant cells. And so the sparser the tumor gets, obviously, the less visible it's going to be on T2, weighted imaging, or ADC maps. Technically, however, another reason for the underestimation these guys reported is that, at least in part, that these ROI contours, they were made on T2 weighted images only. We know that ADC and post-contrast imaging can contribute additional information to the extent of the disease. Commonly, when we plan focal treatments, we kind of synthesize all of the different sequences available to us to design our treatment plan. In addition to that, of course, is that when you're looking at reporting guidelines, when a radiologist typically draws the MR lesion, they are drawing that for the purpose of guiding targeted biopsy, not for guiding targeted treatment. And so we're not necessarily drawing the lesion on every slice and contouring the full extent of it. We're basically contouring the most obvious focus for the urologist then to place a needle into. So both of those factors can, of course, impact these ultimate results that are shown here. Nonetheless, it is accepted that the MR visible lesion only captures a portion of the histologic tumor. And so definitely a margin of tissue needs to be included in an effort to capture all the tumor. Now, some of this can be addressed through machine learning and AI tools. They definitely have a role to play in improving detection and extent of tumor. This is work from Mirabella Rousseau and Jeff Son here at Stanford. We see the results of such a tool in action. This was a model that was trained using pathology labels that were mapped on to MRI as a ground truth. And so the method basically learned not only from the pathology features, but also the corresponding correlating MR features. And then that was then used on subsequent radical prostatectomy specimens. So again, you can see the ground truth here from histology compared to what this machine learning tool found, a very good correlation. The tool was also applied pre-biopsy, again, showing very good correlation between the contour tumor and what the system picked up as well. And we also applied it in cases of known normal glands, or at least normal on MR, and the system didn't pick up any disease there. So some promising results. Obviously, the tool needs further validation, but this is definitely something that can help with identifying the extent of tumor in a way that makes contouring a more robust method, basically, that doesn't require radiologists to sit there and meticulously draw on slice after slice. As a final concept, even after optimal MR imaging, we can see that biopsy can be a source of error. Cognitive versus fusion approaches are used, transectal versus transperineal routes, operator experience, and the number of cores. All of these can impact the outcome of biopsies. For now, although targeted biopsies are better at avoiding low-risk disease, better at identifying high-risk cancer, data has led to the consensus, at least in the US, that the best accuracy comes from a combined systematic and targeted approach. So this is an example where the combined approach of taking systematic cores combined with cores targeted or biopsies targeted at the MR visible index lesion led to improved detection of prostate cancer compared to either systematic or targeted methods alone. 21% in this study had tumor detected by systematic biopsy that was missed by MR targeted biopsy. 10% had a tumor detected by targeted that was missed by systematic. The Edap and colleagues here in the TRIO study group also reported that combined biopsy led to cancer diagnosis in nearly 10% more men than either method alone. They also reported that there was about a 20% upgrade to a higher grade group in the combined approach rather than in using individual biopsy approaches, systematic alone or targeted alone. Importantly, what they also showed is that in men within their study who then went on to undergo radical prostatectomy, the combined biopsy approach led to the fewest upgrades to grade group 3 or higher after histopathologic analysis. Only 3.5% of men ended up with an upgrade compared to the combo systematic and targeted approach. What that had predicted was the grade group of the patient prior to radical prostatectomy. That's quite important, obviously, because we want to be able to depend on those biopsy results to properly select and sort patients for focal therapy. So now back to the concept behind focal therapy. We've seen that in a subset of men that have locally confined and appropriate risk, intermediate risk prostate cancer, if we put these men into active surveillance, we've seen that the quandary faces that these men have to either choose between radical therapies with almost certain impairment and quality of life in terms of things like incontinence and impotence, potential rectal toxicity, or they have to choose for active surveillance where there's a known risk of disease progression, as well as a kind of a psychological burden knowing that they have cancer. As we saw in the PIVOT study, about 40% of men by 5 years had gone on to some kind of treatment. And so for these selected men, we'd like to propose a middle ground solution and see whether or not that works well for these men. And as for the rest of the talk, I'll be summarizing the results of some studies that have tried to target these men with either ultrasound-based high-intensity focused ultrasound methods, MR-guided transurethral ultrasound ablation, or transrectal MR-guided focused ultrasound ablation. So we'll be summarizing these and similar papers that have tried to make this focal approach a reality. So for example, taking this peripheral zone lesion well seen on MR and then focally ablating it, trying to see what does this mean in terms of follow-up biopsy, and also what does it mean in terms of safety for the patient and the reduction in adverse events. So as a summary here, ultrasound-guided focused ultrasound with the Sonoblate system. There are two studies that I'd like to summarize in which the device was used primarily for focal treatment. Guillaume talks about 625 patients. You can see the PSA and the volume of the gland. This device, the transrectal ultrasound-based methods, typically are treating glands that are less than 40 cc's or so. You can see the Sonoblate system here. Men are positioned in a lithotomy. It's a transrectal approach, and there's multiple transducers used for treatment and for imaging. Monitoring is basically looking at how the tissue property changes during sonication using ultrasound as a way of monitoring, looking at things like reflectivity of the tissue. This paper had about nearly 3/4 of the men were greater than Gleason 6 in their cohort, and they followed these men for a median of 56 months. Now, one important factor that of the 625 men, 222 were biopsied, and their approach to biopsy basically depends on seeing that men have had 2 rises in PSA, and then this either leads to biopsy or it leads to an MRI, which then leads to biopsy if the MRI is suspicious. So it's kind of a 4-cause biopsy. It's not that everyone got biopsy for this. So some of these rates of failure-free survival to some extent may be underestimates. Nonetheless, what we see is that if you define failure-free as free from either whole gland therapies such as radiation or surgery or androgen deprivation, 88% of men in their cohort were free of whole gland therapies or systemic therapies at 5 years. Now, importantly, in both of these studies, whether the smaller 625 or the larger more than 1,000 patient group, both of these allowed retreatment in about 1 in 5 men. So if along the way they saw a suspicious lesion, they would retreat that lesion with the same technology and count it as part of the treatment as opposed to going on to further treatment. So different definitions here, but important to keep those things in mind. This, of course, reflects the fact that there is in-field recurrence in about 18 to 19% of these men. And so this retreatment is designed as a way to address this in-field recurrence. Part of this probably reflects the fact that with ultrasound therapy, you don't have, as we saw in the fibroid approach, as I'll show you later in this approach, you don't have the thermometry that comes with MRI to help you with intraoperative planning. Nonetheless, this approach works quite well, as we can see from the failure-free survival results. In terms of adverse events, about 2% with urinary incontinence, immediately postoperatively, about 8% developed UTIs, less than 10% with strictures, importantly, 0.3% with rectourethral fistulas reported in this study. Another version of this is the Edap system, the most recent, the Focal One. There's a couple of smaller studies that have used this for focal therapy in 21 and 24 patients. Again, these patients were primarily early stage disease. So most of them were Gleason 6 disease, although some higher intermediate stage mixed in as well. Shorter term follow-up in these men. Importantly, most of them did get biopsied. Again, a good failure-free survival in the short follow-up. But again, a decent retreatment rate as well. The Edap system here, as you can see, again, a transrectal system, treats up to about 4 centimeters in maximal AP diameter. Interestingly, it has also introduced the use of Sonoview of microbubbles as a way to immediately monitor the postoperative treatment. And so this is a way that could actually allow patients to be immediately retreated if a portion of the prostate appears to have preserved perfusion after the initial treatment. So a clever use of microbubbles and of ultrasound for monitoring in these patients as well, in a way trying to make up for some of the limitations of ultrasound guidance. Now, switching gears to MR, we can't have a talk about MR without either some vectors and an equation or two. Just remember that, of course, with MR, we're talking about protons that are hydrogen bonded. And as we increase the temperature, those hydrogen bonds break, the electron cloud moves away from the protons. And as a result, when the temperature rises, these hydrogen bonds stretch and bend and break. And because the protons are more shielded from the field, it changes the resonant frequency. This mechanism applies to aqueous tissues, not for bone or for fat. But in these systems, what you can do is you can take an image before heating, and these are phase images, and subtract those phase images from phase images acquired during heating. And that difference is basically used to calculate a thermal dose, to calculate temperature and a thermal dose. And you can see that equation, change in phase is proportional to change in temperature with a bunch of constants applied here. And you can use that then, assuming the person's at 37, that the tissue at 37 degrees Celsius, you can assume then that that these patients are, that this tissue has reached a certain temperature for ablation. Now, one of the key points of MR thermometry here is seen in this individual sonication. This is a zoomed in image from a sonication of the prostate. In blue here is the edge of the contour of the left side of the prostate. In red is the edge of the rectum. In orange is the region that we were selecting for a region of treatment. And you can see this sonication spot. And within that, you can see the temperature that the system is generating during the sonication. And one of the things you can see is that even though the focal spots were arrayed anterior to posterior here, you can see that the posterior portion of the tumor is actually heating much better than the anterior portion here. And what this reflects is the inherent heterogeneity of the tissue within the prostate. There's heterogeneity in the amount of stromal tissue and in the perfusion of the tissue. All of these things can lead to heterogeneous temperature rise. With MR thermometry, you can account for that. You can change the amount of power delivered. You can change the length of time that you sonicate that spot. You can re-sonicate a spot to basically ensure before you move on that the tissue you are targeting has reached an adequate temperature for an adequate length of time to reach thermal dose. Moving on to summarize some of the work from the MR-guided transurethral system. Importantly, this paper is actually a whole gland paper, but important, I think, to summarize in this context. Compared to earlier studies with the TULSA system, in this so-called TACT study, treatment control parameters were intensified. The goal here was to reach thermal dose and very close to the margin of the, at the margin of the capsule. And as a result, the controller was designed to deliver at least 57 degrees C at a margin 2 millimeters inside the capsule. Basically, the system is able to modulate power as well as modulate the rotation rate of this transurethral catheter, which contains the ultrasound elements, and can monitor temperature over time as the energy is delivered to the prostate as the device rotates from within the prostate. With this approach, they were able to generate a system that basically would deliver acute cell kill to within 1 millimeter of the prostate capsule with a total volume of acute and delayed cell kill that would cover the targeted prostate volume. The trial treated 115 patients. Again, tended to be about less than 40 cc's of volume. The applicator within the urethra can reach up to about 3 centimeters away from the urethra, and so that limits the size of the prostate that can be treated with this approach. 2/3 of the men had greater than Gleason 6 disease. Follow-up was at 12 months. Almost all the men were biopsied. And importantly, this was a fast treatment with a treatment duration of less than an hour. I think the total room time in the MR is on the order of about 3 hours or so once you're past that learning curve. Again, a transurethral approach. Basically, this applicator sits within the prostate and has 10 independent transducers, each of which can be modulated to treat a single slice, a single 5 millimeter slice of the prostate from apex to base, depending on where the device is situated. What we see in terms of results, the strengths of this study is that this was a multi-center study. The majority of the men had clinically significant disease, although as mentioned, about 1/3 were technically clinically insignificant that were treated. At this point, there's been 3-year follow-up from the study, and the follow-up was done by both MR and MR-guided biopsy, MR and biopsy with a high sampling density, but the biopsy itself was not MR-guided. But in summary, in terms of results from that study, in men that had at least Gleason grade 2 at baseline, 21% had Gleason grade 2 at follow-up biopsy, so 79% did not. Between 75 to 86% of the men maintained potency, although about 1/3 of men had a significant decline after whole gland treatment in erectile function. Very importantly, 90% plus were leak and pad free, so less than 1% in incontinence. 7% wearing a pad a day. You can compare that to the results I showed you earlier for prostatectomy and radiation. vastly improved quality of life here. And if you look at outcomes so far, at 3 years, 87% of men have been able to avoid surgery or radiation or androgen deprivation. So good efficacy and excellent quality of life, excellent safety results compared to current standard treatments. One paper thus far has published on focal therapy. Lumiani, in their cohort, 47 of their patients got focal therapy were treatment naive and got focal therapy. In that group, 90% were greater than Gleason 6. They followed these men for 16 months typically, and of those men, they noticed that 26%, so 12 of them had recurrent disease. Of the men that had intermediate risk disease at baseline, 28% had recurrence after initial TULSA. And some of these men could then be retreated. And if you look at those that were noted to have recurrent disease or residual disease and then were then retreated, ultimately they achieved a control rate of about 87%. So 41 out of 47 men had no evidence of cancer. Pad-free continence in these men, 98%. Maintenance of baseline potency. This is now focal therapy, right? So as opposed to the whole gland therapy that I showed you before, this is an example of a focal therapy approach. So in these men, maintenance of baseline full potency was at 100%. So again, excellent safety results, very good ultimate clinical results. And this is an example of a focal therapy that we've done, a very similar approach to what Lumiani describes. This obvious lesion in the right anterior gland, seen on DWI as well. You can see the thermal monitoring that went on during the treatment here. As we targeted that area, you can see that we did multiple sweeps through the area to make sure that the tissue reached thermal dose. And you can see the immediate postoperative evaluation here showing that not only the tumor, but the margin around that tumor is now devascularized. A very effective approach, an outpatient procedure with few, if any, side effects. Going on to the transrectal MR guided system by Insightec, this is an endorectal approach. It treats up to 4 centimeters away from the rectal wall. It's used only for focal therapy. And monitoring is via MR imaging for thermometry. Again, you can see this thermometry in action. So you can see the small tumor that was outlined here, and you can see in real time the temperature map that's being developed as we sonicate rapidly through that axial slice. This study, which was recently accepted in Lancet Oncology, 101 patients, 100% of the men were either Gleason 3+4 or 4+3. Follow-up was for 24 months. 100% of the men were biopsied at 6 months. 89 of the 101 men were biopsied again at 24 months. And in terms of outcome, we could see that at 6-month biopsy, 95% had no evidence of clinically significant disease. 91% had no evidence of any cancer at the treatment site. At 24-month biopsy, 88% with no significant cancer at the treatment site, 80% with no cancer at all at the treatment site. However, there was disease outside of the treatment region, which of course reflects issues with patient selection and with biopsies, as we were talking about earlier. So an excellent approach for focal therapy, the index lesion. However, screening plays a role here in identifying men that are appropriate for the treatment. In terms of safety, 84% of the men achieved erections adequate for intercourse at 24 months. 100% of the men reported urinary continence. And at 24 months, 90% of the men had avoided other treatment, similar to what we had showed in the other focal therapy approaches. So as I alluded to in the prior slide, part of the challenge here has to do with candidate selection, with choices of treatment guidance, and with methods of follow-up. These things need to be standardized, and there is some convergence and guidelines coming in terms of what size lesion is considered significant, what Gleason grade is significant. Basically, we're primarily targeting patients that have Gleason 7 disease, that's MR visible. They are diagnosed by a multiparametric MR with confirmatory targeted biopsies. Guidance, whether by ultrasound or MR guidance, each has its advantages. With the MR thermometry approach, allowing real-time adjustment of the treatment plan. And then follow-up, of course, you've seen some heterogeneity within these rigorous clinical trials. We had mandated biopsies at either 12 months or at 6 and 24 months. In the clinical practice with the ultrasound-guided HIFU approach that I showed you, they were for-cause biopsies, which can lead to some heterogeneity in the biopsy outcomes. Nonetheless, all showing very good to excellent results in terms of preventing the need for further therapy in these patients. So in terms of the impact on future clinical practice, in general, hopefully I've convinced you that the success of focal therapy depends on the validity of this index lesion concept. And we've talked about some of the pros and cons and kind of back and forth about that, the controversy behind that. I hope that there is no controversy behind the idea that we need better treatment than current whole gland treatments, which it's not clear whether they have clinical benefit in many of these men. And also we do know that they have significant morbidity associated with them. So we can clearly do better in terms of treatment plans and treatment approaches that reduce morbidity. And hopefully focal therapy with these approaches will be efficacious as it's been shown so far and maintain the safety profiles that we've seen in these studies. Clearly, we need improvement in MR and biopsy screening. We need methods that accurately localize target cancers. I showed you some of the innovative approaches with machine learning as well that can help with this. And of course, we need very precise tissue ablation with MR thermometry approaches, or for example, the contrast enhanced ultrasound approaches to confirm treatment. And finally, prospective comparative studies between these focal therapy approaches and standard approaches, whether surveillance or prostatectomy, are now launching. These will be long-term studies to compare outcomes from these patients. Thank you very much for your attention.
Pedji, thank you so much. That was a lot of information and showed a lot of important information comparing the different types of focused ultrasound machines and who we should treat. So thank you very much. Baz, do you have any questions?
Yeah, that was fantastic. Thank you, Dr. Gunani. I mean, it's a really important topic and very nuanced, as you've so elegantly sort of laid out in terms of the treatment options. You know, as an interventionalist, I have a couple questions for you. One, you know, I think in the arena of cancer, especially with local therapies that we offer as radiologists, what has been the response from the radiation oncology community, and sort of what are some of the pros and cons that you could lay out directly there? Because I would see that as sort of the natural alternative treatment that patients would really want to consider, because it would also be sort of either non-invasive technically.
Yeah, honestly, we've been blessed here with a very close collaboration between radiology and urology. So I'll start by saying that I think that is the key thing for anyone interested in this arena, is to have that close collaboration. The same thing is true for us when we treat the brain, neurosurgery, when we do fibroid treatments, to have gynecologists collaborating with us. It's really essential. And frankly, I think it's an easy thing for men, given the knowledge behind what we know about the outcomes from some of the studies that I showed, comparing prostatectomy to radiation to surveillance. It's not clear what the benefits are, depending on which patient population you're talking about. It's not clear the benefits, and the morbidities are pretty well established. And so we routinely have men, all of our men have seen the urologist who goes over surgery and radiation and focal therapy options with them. I see them again to talk about the nuances of the focal therapy approaches that we offer. And many of them, almost all of them, also see the radiation oncologist as well. It has been, I would say, easy for men to seek this approach when they recognize some of the risk factors associated with these other therapies. I would not equate radiation therapy as a focal therapy. People use it as a whole gland plus focal boost, as you know, but it is a whole gland therapy that causes side effects and morbidity surrounding structures that exceed what's happening with these focal therapy approaches that I just described.
Yeah, that's super helpful. That's a great way to think about it. I think from that it's truly not a targeted therapy, and that it's actually a whole gland therapy. And your points about collaboration are well taken. Another quick question for you, and not necessarily I would expect you to be able to comment on this, but just curious what your thoughts would be. The Investigator of the Year for the Society of Interventional Radiology last year was Dr. Sam Woolley from Northwestern, and his paper was actually a canine model for intraarterial radioembolization for prostate cancer. I'm not sure if you've heard about this and where you think that that could potentially fit along in the armamentarium of sort of radiologic therapies.
I wish I knew more about the paper. Unfortunately, I haven't seen it to really be able to comment on it. I presume it was meant to be a whole gland therapy. However, they were delivering
Correct.
on both sides, both are, yeah.
Yes.
So I guess you'd want to know things like what were the postoperative stricture rates and so forth, and of course the efficacy. What would be the advantage of that approach versus the 1,001 ways the radiation oncologists have of delivering radiation to the prostate? Is it? They obviously do a great job of targeting as well with their tools too. I guess I'd like to know more about it before I commented on it.
No, just curious. I know this is a high area of your expertise here, but there's a ton of things out there. Can't expect to know everything. So those are my two main questions for you.
Thank you.
Yeah, no, thanks, Peggy. And Nima, do you have any other comments or questions? I don't know if he's on mute or not.
He said he was on call, so
he's on call. That's right.
He may be gone.
Well,
sorry, I was dealing with a call, but no, I really enjoyed it. It was great. Again, I learned a lot. I hope the audience actually learned along with us. I thought this was really informative.
Yeah, I mean, I'd just like to say thank you to Peggy and Gina for your presentations. I know it takes a long time to prepare this amount of information, and you really did it in such a cohesive way. So thank you. And to the CER team, I mean, to Dr. Kokabi, Dr. Ahmed, and Victoria, it's been a pleasure getting to work with you to organize this event. I hope that the CER team and members kind of start to recognize focused ultrasound as an emerging therapy. And because it's image guided, we need to get all of you guys involved in it. The FUSF Foundation is going to have a booth at the CER meeting coming up in June. And there's actually a focused ultrasound session with Dr. Karun Sharma and Dr. Matsumoto. That's going to be on Wednesday, June 15th from 8:30 to 10. And there's lots of different subtopics in there, from ablation to immuno-oncology, drug delivery, histotripsy, pediatric applications, bone applications. So for those of you on the call today, please come, tell your friends. And if you have any other questions, you can contact the FUSF Foundation. My email address is there, or the FUSFfoundation.org has a ton of information, or contact us directly. Victoria knows how to get in touch with all of us, so I could post it in the chat. But thank you guys for attending, and again, everyone, for your hard work in making today possible. It's just helping to spread the word and helping to create these conversations on how we can move forward and give patients treatments that can be super helpful to them.
Thanks,
Thank
everyone.
you so much, yeah. Really appreciate you taking the lead on organizing this. And as you mentioned, these are really important therapies, and all your efforts to spread the knowledge on this and get everyone up to date.
Okay, take care, everyone.